Advances in medical and surgical care have resulted in 90% of children born with congenital heart disease now surviving into adulthood. As this population ages, their requirement for non-cardiac surgery increases, bringing with it a risk of perioperative morbidity significantly higher than that of the general population. This matrix represents the American Heart Association and American College of Cardiology classification paradigm. It stratifies a patient's perioperative risk by mapping their anatomical complexity, ranging from class 1 to 3, against their physiological status, graded from stage A to D. Patients within the simple anatomy and stage A physiological quadrant, such as those with small, isolated atrial septal defects, can generally tolerate standard anesthetic management in non-specialist centers. The clinical threshold shifts for patients with moderate to complex anatomy, or those at physiological stage B or higher. These individuals require early discussion with or transfer to a specialist ACHD center. For this high-risk cohort, the primary perioperative goal is the absolute preservation of baseline physiological stability. Safe anesthetic management relies on reverse engineering the specific structural modifications of the patient's heart. This allows you to anticipate exact intraoperative failure points rather than relying on generic cardiac protocols. Hemodynamic control in patients with structural heart lesions balances on a single fulcrum, the ratio between systemic vascular resistance, or SVR, and pulmonary vascular resistance, PVR. This diagram shows a ventricular septal defect, creating a standard left-to-right shunt. We quantify this using the QP to QS ratio, the volume of pulmonary blood flow divided by systemic blood flow. A ratio greater than 1 indicates left-to-right shunting, which carries a primary clinical risk of progressive right ventricular volume overload. Routine anesthetic maneuvers like administering high oxygen concentrations or inducing hypocarbia through hyperventilation drop the pulmonary vascular resistance. This physically widens the left-to-right shunt fraction, worsening the volume overload on the right heart. The pathophysiological extreme of this dynamic is Eisenmenger syndrome. Chronic elevation of pulmonary vascular resistance eventually exceeds systemic vascular resistance, reversing the shunt to right to left. During standard anesthetic induction, systemic vascular resistance drops. In a patient with Eisenmenger syndrome, this drop accelerates right to left flow, bypassing the lungs and driving profound, rapid hypoxemia. The mandatory countermeasure is the aggressive, preemptive use of vasopressors to maintain systemic vascular resistance and prevent shunt acceleration. Furthermore, any right-to-left shunt requires absolute air entrainment precautions for intravenous lines. A microscopic air bubble that would normally be filtered by the lungs will pass directly into the systemic circulation, risking paradoxical embolus and stroke. In shunt lesions, anesthetic choice directly controls the physical direction of intracardiac blood flow and systemic oxygenation. Pediatric anatomical correction does not equate to normal cardiovascular physiology in adulthood. Surgically repaired lesions leave permanent physiological handicaps. This illustration shows unrepaired tetralogy of Fallot in its baseline anatomical state. It is characterized by a ventricular septal defect, an overriding aorta, and obstruction of the right ventricular outflow tract. The standard surgical repair involves closing the ventricular septal defect and relieving the obstruction by placing a transannular patch across the outflow tract. The inevitable long-term consequence of this specific repair is chronic pulmonary regurgitation. Over decades, this volume load causes secondary right ventricular hypertrophy and severe dysfunction. The specific anesthetic constraint for a repaired tetralogy of Fallot patient is the strict avoidance of any increases in pulmonary vascular resistance and right-sided afterload. The failing right ventricle cannot push against increased pressure. Because of right ventricular scarring, these patients have a high incidence of ventricular arrhythmias. They frequently carry an implantable cardioverter defibrillator, or ICD, which mandates interrogation and reprogramming by a cardiac physiologist prior to surgery. This schematic displays a mixing lesion, transposition of the great arteries, treated with historical mustard or Senning atrial baffle procedures. These procedures used material to redirect blood flow to the correct ventricle. The fundamental mechanical flaw of the atrial baffle is that it forces the morphological right ventricle to act as the systemic pump, ejecting blood against high systemic arterial pressure for the rest of the patient's life. In the adult patient, this anatomy creates dual vulnerabilities: an extreme susceptibility to sudden systemic right ventricular failure and chronic arrhythmias originating from the surgically scarred atrial baffle. Adult patients with historical pediatric repairs carry embedded physiological handicaps that drastically lower their threshold for intraoperative cardiovascular collapse. We now examine the most complex physiological cohort: patients with functionally single ventricles palliated via the Fontan procedure. This diagram builds the final anatomy of the Fontan circuit. In this configuration, systemic venous return entirely bypasses the right heart. The superior and inferior vena cava are connected directly to the pulmonary artery. Because of this total cavo-pulmonary connection, pulmonary blood flow is 100% passive. There is no right ventricle to push blood through the lungs. The sole mechanism driving this passive flow is the transpulmonary gradient. The transpulmonary gradient is the precise pressure difference between the central venous pressure and the atrial pressure. This delicate pressure balance is heavily disrupted by laparoscopic surgery, requiring pneumoperitoneum, where gas is pumped into the abdominal cavity to create surgical workspace. In a Fontan patient, abdominal insufflation simultaneously collapses the inferior vena cava, choking off systemic venous return, while the increased upward pressure on the diaphragm spikes pulmonary vascular resistance. This dual action obliterates the transpulmonary gradient. The result is a precipitous drop in cardiac output that is entirely unresponsive to inotropic drugs, because the single ventricle has no preload to pump. For Fontan patients, survival during abdominal surgery depends on preserving venous preload and minimizing pulmonary resistance. This requires ultra-low insufflation pressures and the avoidance of hypoxemia and hypercarbia. Transitioning to intraoperative execution, we start with the induction of general anesthesia. Baseline ventricular dysfunction and intracardiac shunts significantly delay the onset time of intravenous agents. Induction requires a slow, heavily titrated approach to avoid catastrophic overdosing and subsequent vasodilation. Regional anesthesia is an appealing alternative. It blunts sympathetic tone during surgery and manages postoperative pain in a population that is often opioid tolerant due to a lifetime on invasive procedures. However, these benefits must be weighed against severe risks. Sympathectomy-induced hypotension is catastrophic in right-to-left shunt patients. Additionally, concurrent therapeutic anticoagulation is highly prevalent in the ACHD population, often contraindicating neuroaxial techniques. Invasive arterial monitoring is a baseline requirement for these complex cases, but standard site selection protocols do not apply. This vascular map illustrates a residual Blalock-Taussig shunt placed in infancy to connect the subclavian artery to the pulmonary artery. Both this and prior coarctation repairs will yield falsely low blood pressure readings in the ipsilateral upper limb, hiding dangerous systemic hypotension. Neither standard induction speeds nor standard monitoring assumptions are reliable within the radically altered vascular geometry of the adult congenital heart disease patient. Moving to the emergence phase, prolonged mechanical ventilation poses a distinct risk by sustaining elevated intrathoracic pressure. We advocate for early extubation to rapidly eliminate the adverse impacts of positive pressure ventilation on pulmonary vascular resistance. Early extubation is life-critical for patients relying on passive pulmonary blood flow, like those with Fontan circuits or those with baseline right ventricular dysfunction. This aggressive extubation strategy is strictly conditioned on achieving normocarbia and flawless pain control. Acidosis or pain will immediately spike pulmonary vascular resistance, negating the benefits of removing the breathing tube. This decision tree matrix maps out postoperative triage. Any patient with moderate to complex anatomy or a physiological stage of B or higher requires admission to a high-dependency unit or ICU for at least 48 hours. This admission allows for continuous monitoring, alerting the team to delayed hemodynamic decompensation and the onset of occult arrhythmias that frequently occur in the immediate postoperative window. Successfully managing non-cardiac surgery in adult congenital heart disease requires the total abandonment of generic cardiac protocols. Safe execution demands exact, lesion-specific physiological targeting.